Good evening, my dear friends from all over the world at Thursday clinical nights at CEC. Tonight we decided to make something a little bit different, a bunch of different STEMI scenarios which are unusual in their presentation. I'm glad to be moderating this session together with Professor Karim Saeed, Professor of Cardiology at Cairo University. And I have on board the elegant CET co-founders, Dr. Abdurrahman Gamal, Consultant of Cardiology at National Heart Institute, Dr. Haitham Suleiman Raib, Lecturer of Cardiology at Fayoum University, Dr. Ahmed Saeed, Consultant of Cardiology at Shibin al-Qom Teaching Hospital, and Dr. Karim Mahmoud, Lecturer of Cardiology at Cairo University. This is a very interesting webinar involving several cases. Each one of them will discuss an unusual STEMI scenario, and we will reach together step by step how to diagnose and how to manage such cases. The elegant scientific moderation of Professor Karim Saeed is highly appreciated as well. I will not prolong the introduction more than this because I'm interested as much as you are to see and watch and hear and learn from this webinar. So I will pass the mic to my dear friend, Dr. Haitham Suleiman, to start sharing the slides and presenting his lecture. So please go on, Dr. Haitham.
Thank you, dear Mohammed. It's always a pleasure to meet 3 times per week in the elegant CEC meetings and lectures. As usual, we are trying to present every interesting topic and aspect of the science of cardiology. One of this interesting aspect is the MINOCA, which is the myocardial infarction with non-obstructive coronary arteries. These are unusual situations. They are not uncommon, and they are challenges in every practice in the way of diagnosing it and properly manage it. So the mechanism of myocardial ischemia is either atherosclerosis, vasospastic disease, or microvascular dysfunction. It's the balance between the demand and the supply. And whether it's a problem inside the lumen of the coronary artery, like plaque disruption or dissection, or the problem is in the wall of the coronary artery, which is vasospasm, focal or sustained vasospasm, or the problem is in the microvasculature, which can produce various types of angina, which is challenging, resistant to treatment, and sometimes can be extremely serious, like the Takotsubo cardiomyopathy. So the mechanism of MINOCA is either plaque disruption, vasospasm, coronary dissection, thromboembolism, microvascular dysfunction, or severe supply-demand mismatch. The diagnosis is made first by diagnosis that this is an acute myocardial infarction, following the criteria of the universal acute myocardial infarction, then doing a coronary artery angiogram to supply or to identify the definition, which is non-obstructive coronary artery disease. That means that we have to visualize the coronary arteries, and then go to the clinical suspicion. What is the mechanism of this MINOCA? The prevalence is not uncommon. As I said, it represents 10 to 14% of all acute myocardial infarction. The third is STEMI, and the 2/3 are presented with non-ST segment elevation. It tends to happen in younger age and in female more than males. 25% of them have an angina recurrent at 12 months. Again, the causes of MINOCA Either it's a coronary cause or non-coronary cause. The coronary cause is vasospasm, coronary microvascular disorder like slow flow, microvascular angina, microvascular spasm, coronary plaque disruption, missed obstructive coronary artery disease, spontaneous coronary thrombosis or dissection or embolism, or non-coronary causes like myocarditis, cardiomyopathy, other a specific cardiomyopathy is Takotsubo or other cardiomyopathies, or a non-cardiac cause like a severe case of pulmonary embolism, renal impairment, stroke, or sepsis. As we said, in order to diagnose MINOCA, we must have a diagnosis for acute myocardial infarction, rush of this patient into the cath lab with urgent angiography. Doing the urgent angiography, if we have an obstructive coronary artery disease, that means that we have a stenosis more than 50%, then we have a traditional STEMI. If we don't have, so we have myocardial infarction with non-obstructive coronary artery disease. And according to our suspicion, what's the cause of the coronary artery disease comes the investigations. Either it's myocarditis, epicardial coronary microvascular problem, myocardial disease, pulmonary embolism, or oxygen demand mismatch, comes the investigations from the simple transthoracic to the transesophageal echo, the cardiac MRI, which plays an important role in ruling out myocarditis and microvascular angina and microvascular disruption, pulmonary embolism with its D-dimer, CT scan, and thrombophilia screening, and oxygen supply demand mismatch with blood test and extracardiac investigations. So I do not want to extend the introduction more because my dear friend, Dr. Abdurrahman Gamal, will present a more thorough review of the MINOCA. So let's start with a very unusual case. This case was presented to the ACC 2019 at the title of STEMI Think Before You Stent. Am I clear, dear Zahran? Dr. Zahran?
Yes, very clear, Dr. Haitham. Please continue.
Okay, there is no questions that, till now.
Yes.
Okay. So we are talking about the coronary spasm. The coronary spasm is precipitated by too many factors, like the age, smoking, the elevation of the C-reactive protein, denoting there is a continuous state of vasculitis and inflammation to this person. The contributions are with activated platelets, the cold pressors, physical or mental stress, Valsalva maneuver, laminin lipoproteins, hyperventilation, magnesium deficiency, central nervous system stimulants like cocaine, non-selective beta blockers like propranolol, parasympathomimetics like acetylcholine, sympathomimetics like epinephrine, and ergot alkaloids. So there is plenty of factors that can cause coronary artery spasm. Coronary artery spasm is usually a benign condition with an adequate flow inside the artery despite the spasm. But sometimes this spasm causes complete occlusion of the coronary artery, and that's when the patient is complaining of angina, and if this spasm persists, he will complain of myocardial infarction. So the coronary spasm, if this spasm is at the site of an organic stenosis, so it will be treated by antiplatelets, atherosclerotic agents like statin, selective beta blockers. If it persists, go to calcium channel blocker and if the pharmacotherapy is not adequate, go to every arbitrary in your pharmacy, and sometimes this persistent spasm can lead to severe atherosclerosis, and you will need to stent this vessel. If this spasm is at a site of other than a site of organic stenosis provoked by an acetylcholine or ergonovine, again, antiplatelet, atherosclerotic agents, and calcium channel blocker. And this patient will represent a low MACE. If there is no spasm with acetylcholine or ergonovine, so this patient will be treated as any other patient with microvascular angina or microvascular disruption. So we have a 45-year-old male, smoker, diabetic, complaining of angina Canadian class 3 for the last 2 years. His ECG shows no abnormalities. Echo showed an ejection fraction of 55% with anterior hypokinesia. There is no other anomalies in his entire evaluation. He gave a history of increased symptoms with intensive medical therapy, meaning that he's complaining of effort angina. Every time he's seeking medical advice and any of the healthcare professionals intensify his medical treatment, the patient condition worsened. So the coronary angiography was decided. Before the elective coronary angio by 1 hour, the patient got panicked with severe chest pain, and with this ECG showing an acute anterior myocardial infarction. Fortunately enough, the patient was inside the hospital in the preparation room for the coronary angio, so he was rushed to the cath lab. And this is his first view. You can see that there is a total occlusion of the LAD and more or less a slow flow inside the circumflex and especially in the OM branch. Another view, the left main is intact and the obstruction is at the proximal LAD. With the third view, there is here a strange phenomena is occurring. If there is anything strange you're noticing here, Zahran, Ahmed, anyone?
I think, Dr. Aysam, the diagonal is starting to appear.
Yeah, we have a dynamic change in the level of occlusion without any obvious intervention. Just the pressure of the contrast changed the level of obstruction of the LAD, and the diagonal branch is starting to appear. So the right coronary was normal. So we introduced a wire, guiding catheter and wire, and after the introduction of the wire, this happened. There was restoration of the flow inside the LAD without any intervention. This is another view with a complete restoration of the flow inside the LAD. So now, the flow is restored. What to do next? Stent the LAD, and where to stent in the LAD, or to do another procedure? What do you think?
Professor Karim Saeed, are you there with us?
Yes. Good evening, everybody.
Professor Karim.
Are you hearing me?
Good evening, Professor. Yes.
Good evening, Haitham. Good evening, Dr. Muhammad. Actually, this is a very interesting case, especially with your, let us say, introduction. You are trying to direct the discussion towards the possibility of spasm or mynoca, and I want to open the discussion further. Why not to consider this as very early MI, and this is a thrombotic lesion with successful spontaneous lysis, and this STEMI 2 to 3 flow is established by wire passage, which is very common. I will ignore the possibility of spasm unless you are providing a very convincing clue for the occurrence of a spasm. This may be a thrombus.
Okay.
Solved. So in this case, which is not uncommon situation, the role of intracoronary imaging using IBIS or OCT is very important. Sometimes you will find feature for disrupted plaque with overlying thrombus, and this plaque may be an obstructed plaque despite this apparent normal angiography, and you are going to stent it. The other possibility, if it is a non-occlusive plaque, this is a controversial issue. Some will implant a stent and others will not. So in my thinking, the role of intravascular imaging with IBIS or ECT is a priority in this situation.
Of course, Dr. Karim, the role of intracoronary imaging is essential. But if we do not have on board intracoronary imaging, which is a common scenario, especially in Egypt, what do you suggest to clarify the mechanism of occlusion of this artery? Now we have an opened LAD with just the passage of the wire. There is no apparent remnant of a thrombus, and there is an adequate blush to the distal myocardium supplied by this LAD. I'm trying to brainstorm the possibilities and, of course, benefit of your experience. What do you suggest to do?
Can we have other views to show this proximally?
This is the other. Mm-hmm. This is the other view showing the proximally occluded segment, or the segment that was previously totally occluded.
In this situation, I will opt for medical treatment, as long as I can find evidence of obstructed plaque.
Okay.
The middle segment of his LAD showing some systolic compression, or it is not.
So there is a doubt.
I have Dr. Muhammad Hosni, lecturer of cardiology at Cairo University. He's saying, why not inject nitrates and C? And I have a vote for doing nothing except adequate medical therapy, like Professor Karim said. And I have someone asking why, if there is a slow flow in the rest of the coronary circulation, including the circumflex, if we are speaking about a thrombus in the proximal LED or in the diagonal. So the flow will be slow only in the affected artery, but we have something like slow flow everywhere. So they are thinking about something rather to be affecting the whole coronary circulation than being confined to one coronary trip.
So let's wrap up the possibilities here. The possibility is that this was a thrombus that was dislodged and disappeared after passage of the wire, or this is a microvascular disease, especially that we have some sort of slow flow into the circumflex also, and not only in the LAD. Other possibility raised by Dr. Karim, that there is a doubt about the mid LAD. This part is doubtful if there is systolic compression or not. And Dr. Muhammad Hosni is suggesting to inject intracoronary nitroglycerin to see its effects upon the flow and upon the segment of the mid-LED. And that's exactly what I did. I pulled out the wire and injected nitroglycerin. And this was the result. The mid part has a near 90% systolic collapse. Do you agree, Dr. Karim? Dr. Karim Saeed.
I can see, Haitham, what you described. Professor Karim, what Haitham did is exactly what you suggested, to take the wire out and inject nitroglycerin for the possibility of a myocardial bridge affecting the mid-segment of the LED, and this is what he got. Would you consider this a significant myocardial bridge, and how would you suspect a myocardial bridge on the coronary angiography?
I want to give some observation, then we can discuss a final conclusion.
Please, please go on. You want to watch more views?
Okay.
Okay.
And this was
this is the previous.
I mean,
RAO cranial view.
The index angiogram.
This is after. Yeah.
The occlusion was proximal to the diagonal.
Yes.
In the first shot was proximal to the diagonal, and after two injections, the occlusion was after the diagonal branch.
Yes, but the ECG, it was ST elevation starting from early V1 and V2, and the site of the occlusion was consistent with proximal LED. So I'm not sure this mid LED related to the bridge or systolic compression is the culprit. This is a point. The second point, the distal part of the LED doesn't move. So it is akinetic, and maybe the proximal segment to this distal LED is hyperkinetic with compensatory hypercontractility. And with some intramural course, we can see this milking or systolic compression consistent with a bridge or intramyocardial course. So I cannot correlate the site of the occlusion based upon the ECG and based upon the index angiogram as a culprit lesion with this middle segment, long segment intramyocardial bridge. It may be coincidental, or it may be a compensatory hypercontractility relative to the distally akinetic or even dyskinetic segment.
Okay, so in your opinion, Dr. Karim, what caused the acute myocardial infarction? Still the possibility of an acute thrombus is there?
In the second angiogram, you showed this sluggish flow at the diagonal, and the LED may be due to distal embolization of the thrombus into the diagonal as well. So I am still eager to rule out a culprit lesion at the proximal segment of the LED. This is important.
Sorry. Okay.
So let me ask a question, Professor Karim. If we want to diagnose an intramyocardial bridge affecting the LED, or first of all, I would like to ask you, have you seen or read about myocardial bridges affecting vessels other than the LED? This is the first question. And the second question, if I want to accurately diagnose it, would I perform an MRI or a CT?
Okay. Definitely the classic feature of the myocardial bridge is being affecting the LED, especially the mid LED. However, there is some rare reports for bridging affecting other vessels. It is not exclusive to the LED. However, it is by far the most common site for myocardial bridging. The role of imaging, we should show a systolic compression with narrowing of the lumen. CT may show intramyocardial course, which is not a diagnostic feature for bridge. It should show also systolic compression of the vessel. Intramyocardial course is very common among healthy individuals, and it is not a prerequisite to diagnose, or it is not a diagnostic feature to diagnose a myocardial bridge. MRI also can show this phenomena. However, the spatial resolution of the MRI to show the lumen of the coronaries is less than that of the CT coronary angiography.
Yes. So we mean, or we can translate those words that myocardial bridging or significant myocardial bridging is both anatomical and function. It needs the LED to pass within the myocardium as an anatomy, and this myocardial contraction causing systolic compression of the LED, and this is what affects the function. So sometimes you can find an intramyocardial course of the LED, but it is not causing a significant systolic compression of the LED, and this is one very important point which I was aiming to hear as an answer to the question, and you successfully elaborated this, Professor Karim. So for this particular case, I have also a feedback from Muhammad Hosni at Cairo University. Muhammad is saying that he votes that the myocardial bridge may have caused a spasm in the whole LED length or mainly proximally, and this caused the proximal occlusion rather than having a ruptured plaque with a thrombus at the proximal LED and myocardial bridge in the same patient, which I actually find may happen, but also very unusual. But I cannot find a clear-cut explanation for why the flow was totally blocked very proximal to the occlusion by the myocardial bridge, unless we have a very long thrombus extending from the proximal to the mid-segment of the LED. And then the question would be, where is this thrombus now?
Actually, Zahran, this is the mechanism that I vote for, that this myocardial bridge caused the spasm, and indirectly, it's not the direct effect of the bridge. It was the pain caused by the bridge. If we see the sequence of this patient was terrified from doing a coronary angio. He was panicked with severe tachycardia, severe chest pain caused by this bridge, and then a myocardial infarction. And we all know that one of the mechanisms of spasm is emotional or physical stress, excessive emotional or physical stress. So this myocardial bridge contributed indirectly in the mechanism of Menoka, causing the pain of the myocardial bridge caused severe spasm in the coronaries, which lead the patient to acute myocardial infarction. I think this is my explanation to this case. Dr. Karim, what do you think?
Professor Karim, I would like to hear your opinion also. Professor Karim Saeed, are you there?
Yes. In absence of intravascular imaging, all we have will be speculations. Let us start by having a typical patient for atherosclerotic heart disease. He's a male, he's a diabetic. He definitely has regional motion abnormalities at the echo. He has effort angina, not resting angina, which is typical for the spastic angina. So by history, this is a classic feature for atherosclerotic coronary artery disease. This is a point. And the ECG, as well as the first angiography, is consistent with the proximal LED lesion. And now we have this long mid-LED lesion that may or may not contribute to the pathogenesis of this MI. So if we are believing that the proximal lesion was the culprit, this patient will have a medical therapy. On the other hand, if we are believing this mid-LED is a culprit lesion, this will increase the challenge for the management of the case, because we know PCI is not a good choice for the management of this mid-LED lesion, bridge, I mean. Finally, could we label, if we believe this is mid-LED bridging as a cause of MI, could we label this as aminoca? Because now we are having definitive obstruction of the lumen, more than 50%. And so this is an MI with significant obstruction of the lumen. Yes, it is not atherosclerotic, but it is an obstructed lesion. So we have a cause, and one of the requirement for the definition of the aminoca is not to have a definitive etiology at the time of performing the angiography, or a patient coming with a picture consistent with MI. So it's very interesting to know what was the management of this patient, and the long-term follow-up and the medical treatment he had received.
Actually, I'll skip the slides that are discussing the myocardial bridge. Quickly, the myocardial bridge have several types, and the classification is depending about how deep this artery is embedded inside the myocardium and what the myocardium is doing to this vessel, either simple compression or compression with atherosclerosis, or compression even with dissection. The presentation of bridge varies from asymptomatic patient angina, acute coronary syndrome, MI, arrhythmia, or sudden cardiac death. And the diagnostic tools are various. The invasive coronary angiography is the most common here in Egypt, but the most common finding is during the multi-slice CT. This patient was sent to surgery actually to do a supraarterial myotomy. He's asymptomatic. Now it's for 2 years, 1.5 years. The ejection fraction improved to 60%. The mid-anterior hypokinesia disappeared, and he's on that statin and beta blockers. So I sent this patient to surgery to do a supraarterial myotomy. And once he did it, his symptoms disappeared completely.
Very interesting and very good outcome for the patient. But if you are going to meet this patient again, Haitham, with the same scenario, what would be the different steps in the management? Would you still
I will struggle to do him first an intravascular imaging before jumping to any other modality of treatment or management. This is the missing step that I will try to do.
Yes, I think so.
Probably this patient had definitely one of two problems. One of the problems was the myocardial bridge, and this is definitely we all agree upon. What we are really inquiring and brainstorming to think is what happened in the proximal LED. And here, if you want to visualize the endothelium, if you want to visualize a thrombus or a cracked plaque or something like this, it's better to perform an OCT to see the endothelium of the artery, to see the atherosclerotic plaque, to see the rupture and everything. And this raises an important question because I hit this situation several times in my practice, Professor Karim Saeed, and I read about it in the literature a lot. And as you said, there is lots of controversy. Let's say that I have a non-significant lesion in the proximal LED, and this non-significant lesion is a ruptured plaque, definitely, and it caused a thrombus that got the patient a non-ST myocardial infarction, for instance, with a non-total occlusion of the vessel. And then with my injections, the thrombus cleared the way and moved distally to the microcirculation. And now I have a clear LED with a small 20% plaque and the wall of this LED. For me as an operator, what I learned and from what I read also, 99.9% of the cases, giving this patient adequate dual antiplatelet therapy and a good high dose of statins would help him to heal his plaque and solve the situation without the need to put a piece of metal or stent there. But I was also facing other operators that said this is an ulcerated plaque, and if I leave it per se, the vessel will be reoccluded again tomorrow or after tomorrow. So I would like to stent a lesion. And here I would ask a question: is the stent a therapy for the plaque or not? I would like to hear your insights about this issue, Professor Perry.
This is a very difficult question, despite being a common scenario, and there is no consistent answer for the management. However, there is an important step, intravascular imaging to start with. Sometimes what looks like as an insignificant plaque will turn out to be a significant plaque, especially when we have a heaviness related to the thrombus and the vasoconstriction related to the acute MI setting and the diminished flow. So IVUS or OCT will give some insight. If still we have evidence by OCT or IVUS of non-significant lesion, some operator believe in passivation of the plaque by stenting, which is not supported by good evidence. And other many operator, as you delineated, thinking that DAPT, high dosage statin, is enough to passivate the plaque, and the patient will have a very good long-term outcome. So I think intravascular imaging, then to decide for myself, I usually go with medical treatment.
For me, Professor Karim, I totally agree with you. And this is my practice. And really, when I follow up those patients, they do not need, in most of the cases, they do not need other than adequate high-dose statins and adequate medical therapy, including dual antiplatelets, and they never got a reinfarction or a reocclusion of the vessel or something like this. But actually, the other side of the story would beg to differ with us, because most of the plaques that cause acute coronary syndromes are mostly those plaques that do not cause a significant stenotic lesions. So the debate is always there, as you demonstrated, Professor Perry. Haitham, do you have anything to add before wrapping up this case?
No, I want to highlight the management of myocardial bridge, because this is a common scenario found in our practice. If this bridge is not causing any symptoms, especially if it's an LED bridge, so we relieve the potential triggers, especially the factors that it's causing tachycardia. We modify the risk factors, and we consider antiplatelet therapy if there is evidence of atherosclerosis. If there is clinical symptoms, beta blocker, calcium channel blockers are needed. We can consider further control of the heart rate using ivabradine together with lower dose of beta blocker, calcium channel blockers. We avoid pure vasodilators, especially that those patients are reporting more angina and more symptoms when using more potent nitrates and pure vasodilators. We relieve the potential triggers, risk factor modification, and consider antiplatelet therapy, especially if the myocardial bridge is causing an acute coronary syndrome like our patients. If there is no improvement, There is an extreme controversy about stenting a myocardial bridge. It can cause stent disruption or dissection or growing atherosclerosis at the two ends of the stents. The gold standard therapy is to do surgical intervention, either by cabbage or supraarterial myotomy. So this is to wrap up an everyday scenario of myocardial bridge. And thank you so much.
So much, Haitham. This was a great debate, and we learned a lot from the insights of Professor Karim Saeed. Ahmed Saeed, are you ready to start sharing your screen? Yes, Ahmed is there. So the second speaker today will be Dr. Ahmed Saeed, consultant of interventional cardiology at Shmini Home Teaching Hospital. Dr. Ahmed Saeed will present a very interesting clinical case open for discussion also between the audience. So please proceed, Dr. Ahmed.
Good evening, everybody. This is Ahmed Saeed presenting this case today, unusual scenario in STEMI. We have a 35 years old lady. She is pregnant, 36 weeks. She is not diabetic, not hypertensive. She presented with acute chest pain of 3 hours duration. Her ECG showed the ST segment elevation in the inferior leads. So she was taken to the cath lab, and this is the coronary angiography. Here we notice the patent LAD and LCX. And here, this is the RCA. We consider it the culprit. So what do you think is the cause of inferior STEMI in this lady? Is it coronary thrombosis or coronary dissection or coronary spasm? So please, we are waiting for your votes.
So for our friends on the YouTube, you can start voting, please. As you see, there is a filling defect or something unusual in the mid-segment of the right coronary artery. In 36 weeks, that means that she's near-term pregnant lady, young lady, which presented by an acute inferior ST segment myocardial infarction. Would you vote for coronary thrombosis, coronary dissection, or coronary spasm?
Dr. Ahmed, can we repeat the right coronary angiogram because we didn't have time?
Yes, of course, Professor Karim.
Keep it playing.
She has a short left main, so we needed just minimal advancement of the diagnostic catheter to selectively inject the LAD and the LCX. And this is the angiography of the right coronary artery.
Okay.
So here we have a TIMI3 flow in the left circumflex, and the LAD vessels doesn't look atherosclerotic, but it's patent. We have here in the right coronary artery this mid segment. We will discuss its description in the next coming slides. So we have here, what do you think is the cause of STEMI, thrombosis or dissection or spasm? Dr. Zahran. So some on the YouTube, they are telling it is thrombosis, and also one of the answers is dissection, and one Dr. Amira is telling fibromuscular dysplasia. So you mean by fibromuscular dysplasia, it is a dissection. So here is the answer. It is coronary dissection. So what is the definition of spontaneous coronary artery dissection? It is defined as an epicardial coronary artery dissection that is not associated with. So we have here three conditions to be fulfilled to say it is a spontaneous coronary artery dissection. It's not atherosclerotic, and it's not traumatic, and it is not iatrogenic. So we have here three types of coronary artery dissection, spontaneous coronary artery dissection. Type 1 here, it's clear that we have that multiple lumens or the double lumen contour with the radiolucent contrast material. And this is the most clear and geographic type of the coronary artery dissection. Here there is no, it's not a must to have the staining or the stasis of the contrast media to say it is type 1 dissection. Only once you have this multiple radiolucent lumen, so you can say it is type 1 coronary artery dissection. In type 2, we have a long, diffuse, and a smooth narrowing of the vessel like this one, while having normal epicardial coronaries of the resting vessel and other vessels. So we have here normal texture and very long diffuse, most probably more than 30 millimeter of a smooth narrowing. So this is corresponding mainly to intramural hematoma. The type 3, which is just a focal tubular stenosis, and this one mimics the atherosclerosis. So we have here in this type 3, you have to, once I say this is a type 3 coronary artery dissection, I have to have an objective evidence like the OCT or the IVOS that showing intramural hematoma or a double lumen appearance. Type 2, by the way, is the most common type of coronary artery dissection. So which type of SCAD is this case? Here, this is the angiography. Please, our colleagues, we are waiting your votes. Which type? Is it type 1 or type 2 or type 3? So Dr. Karim, if you please.
Okay. First, when I saw this right coronary angiography, I saw there is some linear filling defects across the middle segment. Being a pregnant, the possibility of dissection is high, despite the fact that in pregnant women, the most common site for dissection is the LED, not the right. When the coronary is affected due to aortic dissection, it is the right. However, in pregnant female, it is the mid-LED or the LED. So the differential diagnosis would be a dissection or organized thrombus. And Dr. Karim Mahmoud had a comment that we cannot be sure that this is a definitive dissection based upon the angiography. However, if we are going to be a spontaneous dissection, I will vote for type 1, having this linear defect as I can see through this angiogram. What do you think?
Yes, sure. This is also my idea. It is a type 1 dissection, and the pregnancy associated dissection is the most common type of MI in pregnant women, not in women in general, but in pregnant women. So here, from the histopathological classification, this is the normal artery. We have here the lumen and the intima, and then it is surrounded by the media and the adventitia. This type 1 is really just at the intimal tear that make the blood go from the true lumen into the subintimal or between the intima and the media, making this dissection of the intimal flap, making a true lumen and a false lumen, with expansion of that false lumen hematoma, causing significant obstruction of the true lumen and the acute coronary syndrome. Which one is first? Is the hematoma that causes the tear or the tear that caused the hematoma? It is really a controversy. The second possibility is like rupture of the vasa vasorum that inside the subintimal tissue or the media and adventitia. So it will cause expansion of the hematoma, and this type explains type 2 and type 3 of the dissection. You don't see that intimal tear, and you only see this hematoma. And this is the histological appearance. This is the false lumen and full of the hematoma that is compressing the true lumen and causing significant obstruction of the true lumen. And this is the true lumen compressed by the false lumen hematoma. So which one is the most common associated condition with this dissection, spontaneous coronary artery dissection in females? So here we have, these are the causes: fibromuscular dysplasia and the pregnancy, multiparity, inherited arteriopathy and connective tissue disease, Marfan and other vasculitis causes, exogenous hormones, and some oral contraceptive and postmenopausal and infertility treatment, also postmenopausal therapy, and testosterone and corticosteroid, systemic inflammatory diseases like systemic lupus and Crohn's disease, ulcerative colitis, and etc., migraine and coronary artery spasm. So which one is the most common associated condition of these associated conditions, dear colleagues? If you just vote. So Dr. Karim, what do you think about the associated conditions?
There is many literature saying that the most common association for spontaneous dissection is fibromuscular dysplasia in the majority of patients.
Yes, actually, it is the most common. It represents about 25 to 60 to 86, and the pregnancy is actually is not that much common cause of or association with coronary artery dissection. So regarding the epidemiology, we have SCAD was initially described as a rare and almost universal fatal cause of acute coronary syndrome and myocardial infarction and sudden cardiac death in peripartum women, but contemporary reports has rejected this misconception. The SCAD is occurring overwhelmingly in women, and it may be the cause of ACS in up to 35% of MI in women less than age of 50 years old. It is the most common cause of pregnancy associated MI is SCAD. So our plan of treatment in this lady could be conservative or percutaneous coronary intervention or referral for cabbage. Dr. Karim, can you please just tell us your idea about the plan of treatment?
Okay. As a rule, in patients with spontaneous dissection, we opt for conservative management. And the majority of cases will have a favorable course with conservative management. However, some minorities with continuous chest pain and the continuous ST segment elevations and ongoing necrosis should have some intervention by ballooning, and it is a very challenging procedure. Putting a stent in these lesions will beget further dissection distally and proximally. So the message is that conservative treatment is a ideal management for those patients, especially with this pregnant lady.
Yes, of course, sir. This lady is having ST elevation and ongoing myocardial ischemia and acute coronary syndrome, and she is having persistent chest pain that did not respond to the medical treatment. So
if this is the case and we have ongoing infarction, so we should intervene. CABG is not, I am not sure CABG has a role here with this lady. We will go for PCI, and here we have many tips and tricks to do a safe, effective PCI with this.
Dr. Karim,
Yes, you can proceed, Dr. Ahmed.
Yes, sir.
Yes, I am with you.
So taking the decision either to go for PCI or CABG, it will depend on the coronary anatomy of the patient and the operator experience as well. So here we have taken the decision to go for PCI, taking in consideration that it has more risk of complications because of the weak architecture due to the underlying arteriopathy. So we have the Mayo Clinic series of 189 patients initially managed with PCI, presented with acute coronary syndrome and SCAD. So PCI technical failure was in 53% of the patients. Emergency CABG was required in 13 of those treated with primary PCI. Emergency repeat PCI needed in 4%, and there was one death. In a European study, 134 patients, 27 of PCI's failure, and 9% of patients required emergency CABG. So when we decided to go for PCI, which one is better, femoral or radial approach? When you are suspecting a SCAD, like this pregnant and having MI, we were suspecting SCAD from the beginning. So to go for femoral or radial approach, Dr. Karim?
I will go for radial to minimize radiation to the lower part of the body.
Okay. So the preferential use of femoral access or extra caution with the radial catheterization in a retrospective series in which there was a threefold higher risk of catheter-induced iatrogenic dissection in patients with SCAD undergoing coronary angio when radial access was used as opposed to the femoral. And this also depends on the operator experience, as we said before. So the experience here is the rule of decision. So we have to take care in SCAD because the wire may enter in a false lumen like this one. Once it goes into a false lumen, and it will expand the false lumen, and you will advance your instrument, so you will block the true lumen, and then you will struggle how to return again. Dissection, stenting a dissected segment with the regular length of we are using in atherosclerosis, it may cause a hematoma propagation, the intramural hematoma, to be propagated proximally or distally, or the dissection also to be propagated proximally or distally. So we have to use a long stent, 5 to 10 millimeter proximal and distal, covering the whole dissection. So when there is an intramural hematoma, we can make like a cutting balloon fenestration of the intramural hematoma to allow a decompression of the false lumen blood to pull into the true lumen. Another trick is to use a multi-stent approach and then to stent the proximal and the distal ends first with the stent before stenting the middle to minimize the intramural hematoma propagation and the dissection propagation. Some decided to use the bioabsorbable scaffold, the BVS, that was in the era of BVS, to provide a temporary scaffolding because they know that there is no atherosclerosis, so he needs the scaffold to be reabsorbed after 2 years. So what is the next step after wiring the lesion is to use OCT or IVUS or only balloon angioplasty, 3 direct stenting, or to go balloon angioplasty plus stenting. Dr. Karim, if you have any comment.
I don't have managing spontaneous dissection, but imaging to be sure that I am within the true lumen. This is a point. The second point, I will not go for ballooning. I will go for stenting, and I will not go by high pressure because possibility of dissection and rupture and the perforation is not low. I will not oversize this, and I will be very careful not to cause a dissection proximal to the index dissection. That is my thinking.
Yes, that's also, we have decided to go for direct stenting, that segment. So we didn't choose to go for OCT or IVUS, beside it is not available at that time in the acute coronary syndrome management. It may cause extension of the dissection or the hematoma distally or proximally by the catheter, or even by the contrast that we use in OCT, or technically during OCT, we inject high amount with high pressure of contrast to clear the blood, so the OCT image to become clear, so the contrast can expand the dissection proximally or distally. The second thing is only balloon angioplasty. It will take a long time inflation to seal the dissected intima, so it will cause more ischemia and prolong the time for the procedure. Also, we keep balloon plus stenting if direct stenting fails to cross. So we decided to go for direct stenting. Here, you see that passing the stent was a little bit difficult, so we have to position the guiding catheter properly to give little extra support. But here we have to avoid deep catheter engagement. We have a friable vessel that can dissect easily. And also here at the ostium, any dissection can propagate into the aorta. So we have to avoid the deep engagement of the guiding catheter. We have to keep non-coaxial position of the catheter tip, and then to avoid also catheter dampening. And then positioning the stent proximal and distally to the dissection, and avoid strong contrast injection, because strong injection can expand the dissection proximally or distally, as we said. So here, this is the deployment of the stent. We have to use as a 1-to-1 stent size. We don't oversize the stent, and we have to go for nominal pressure because high pressure can expand the dissection either proximally or distally. And that was the result after stenting that segment. We have a TIMI-3 without any expansion of the dissection or the hematoma proximally or distally. And this is the second image, cranial view. And that is the last image. It is a lateral view. We are here taking more than 1 or 2 views just to be sure that there is no any extension of the dissection or an intramural hematoma proximally or distally that may cause re-infarction later on if it expands. So Dr. Karim, if you have...
Excellent result, Dr. Ahmed. Congratulations. This is a very unusual case. Unusual to have an infarction in a pregnant lady. Unusual to have a spontaneous dissection in a pregnant lady in the right coronary artery. Unusual to manage spontaneous dissection with PCI, and unusual to have a very successful PCI for a spontaneous dissection. As you said, the failure rate is very high, and you have achieved a very good results. Do you have any data about the DAPT therapy and the delivery and the long-term outcome of this patient?
Yes, she delivered on time, and she delivered by normal labor inside the hospital also. The obstetrician was trying to stop the DAPT also. We disagreed. She was admitted to the hospital, and then she had the normal delivery. She was discharged on dual antiplatelet aspirin 75 milligram once daily, and clopidogrel 75 milligram once daily also. We didn't give her statins, as statin has no role here in coronary artery dissection. We didn't give also any, of course, any beta blockers or AC inhibitors because of the pregnancy, even after delivery.
Excellent results.
But let's say that if this patient already got a STEMI, so that the duration of dual antiplatelets would be for 1 year, like any regular STEMI. Do you agree?
If stenting only, Zahran, if we have put a stent, so we are using the dual antiplatelet because of putting the stent. But the SCAD, the mechanism is different from the atherosclerosis, so we don't need if like we said, we will go for medical management and she is stable and not in ACS, we will go only for aspirin. Also, the use of heparin here, it's controversial. We used it during the intervention because of the catheter thrombosis rather than the thrombosis inside the coronary.
So I can see that you have another case to present.
Yes.
So I will leave the remaining time for you to do the second case.
The second case is a 30-year-old gentleman. He is not diabetic, not hypertensive. He is not a smoker. He presented with acute severe chest pain during gym exercise. His ECG at the emergency showed the Willen criteria. Then suddenly he collapsed and arrested on VF. He resuscitated and received DC shock, and then he survived. So the second ECG showed the acute ST segment elevation in the anterior leads. So he was taken to the cath lab, and that was the angiography. Here we see a normal right coronary artery, and this is the caudal view. Here we see also the normal LCX and the ramus. We have a total occlusion of the LAD proximally just at the ostium. What do you think, Professor Karim, of this coronary angio?
It is a super dominant one. And
yes, Professor. I don't know. I am clear, or Dr. Karim disconnected?
I am with you, Dr. Ahmed.
Yes, please, sir.
I can see the right curve good, and it provides the retrograde flow to the LED, but I want to see the left angiogram properly.
Actually, I see this small branch. It is not the LED. I think it is like an atrial branch, or it's not that LED vessel, I think.
Okay.
Actually,
This extension of the right. Can we see it
yes.
again? This one, yes. Maybe.
Yes,
Okay,
actually,
what
this
I
case
can
was
see,
done.
this is just occlusion, that occlusion of the proximal LED and the long left main. That is my comment.
Yes. That case actually was done by one of our colleagues. He was doing, and then he decided, he thought it's a thrombotic occlusion of the LED. As anyone just see the coronary angio, it's clear it's a thrombotic occlusion of the LED. And then he tried to start with the wiring. He tried with multiple wires to go, but actually he couldn't cross. Even he tried to use a balloon support, as in this view. Actually, the wire was not going any way. He tried multiple wires, multiple different wires with, even he reached the pilot 200, and also the wire was not going. He tried for 2 hours continuously, until he fatigued from that, and the wire was going like this view.
Yeah, there will be another ectopic course he can try in other directions with
Yes.
other vessels, maybe.
This is a second trial to go with the wire. It was going in a strange direction. And this, the next one is coming. And he is taking multiple projections, and the wire still doesn't want to go for a straight course. That as the anatomical landmark of the LED, which is the cause of the MI. These are multiple trials, and then after I arrived, he was fatigued and he asked me to continue. So I went there. I tried all the wire he tried until I got this image. Here, Dr. Karim, what do you think this wire is going inside the true lumen, or just this like a snake appearance? It could be in a false track.
Difficult to tell, but sometimes we have seen such course, abnormal course for the LED. Sometimes. Okay. Dr. Karim Mahmoud raised an important issue. Do we have a very good retrograde flow or contralateral flow to see the continuity with the LED artery?
The problem is that RCA is not filling the LED at all. It was filling.
There is no retrograde flow.
No retrograde flow at all.
Okay.
Because he was already taken to the cath lab, because he arrested in front of the cath lab. Just before he's going, he was transferred from the ICU, from the emergency to the cath lab, and then he arrested and resuscitated and directly went to cath lab, even less than 30 minutes.
Okay, so now you have steered your wire into the distality of a vessel that may be an LED with an ectopic abnormal course, and now you want to be sure whether this is an LED or something else. That's right?
Yes, and also the balloon was not going. This is the issue. Also, after putting that wire in this segment and trying to push the balloon, it was a 2 millimeter balloon. The balloon was not going. So after multiple trials, we made like an acute bend of the pilot, like this. This is the balloon, just go like this and then stop. It doesn't go more.
Okay, lateral view. One of our.
Yes, it is coming now. Just loading the slide. Yes, this is the lateral view. In the lateral view, we could pass the wire like this. And then we could pass the balloon over the wire after that with little difficulty. And before inflation of the balloon, we had this angio after passing the wire.
Could you please beside an aneurysm or ectatic segment, large ectatic segment?
What do you think, Dr. Karim, now?
You inflated the balloon?
No, till now, not inflated. Just push the wire and then push the balloon over the wire to ensure that it is going down and they came out without inflation. Because also I don't know where is the wire going, so I could be outside the coronary. If I inflated the balloon, I could make
I think you are still in the LED, in the lateral view, your wire.
Yes.
We're reaching the apex, overlying the anterior border of the heart, despite this abnormal course. This may be abnormal course, there may be a huge aneurysm. I'm not sure, but you can probe with your balloon with a small inflation till having a definite flow.
Yes, we after we passed, we dilated the proximal segment with the balloon, and then this is the coming slide. We dilated the proximal segment with the same 2 millimeter balloon. And that was the angiography after that.
Okay.
So here we have this the same as double lumen proximally here in this segment, and a severe long segment of stenosis over the wire till mid to distal LED. It's a little bit taking time to load the slides. So which type is this dissection? And one of the difficulty of this case was the very bad cath lab machine, and the images were really difficult to have a clear judgment.
Looks
But
like a hematoma.
Yes. So we have here the two types at the same slide in this angio. We have type 1, which is the multiple lumens here, and this is the white one. And the second, we have the long and diffuse narrowing, smooth narrowing of the vessel, taking in consideration the normal other coronaries that we see in the right coronary and the circa and the ramus. They are clearly normal. So this is most probably a dissection that it was a very long dissection. I think our wire went behind the intima and then returned again to the true lumen with the multiple attempts and the trials with the heavy wire. Also, the pilot 200 is the best to return into the true lumen when you make an acute bend like this in the proximal and then puncture with the wire, you can reach the true lumen. So here we decided to stent from the proximal to seal the entry point, and then to stent from the distal to seal the exit point or the hematoma. And this is the post-dilate. This is the stenting proximal, and this is the stenting the mid to distal segment. And we used this. It was the longest stent at that time, and we had this angio. So what about this distal propagation of the intramural hematoma that went after the distal stent, Professor Karim? What would you choose to do for this one?
I can't see the angio, Dr. Ahmed.
It's not clear now? The angio is clear in my side. I don't know.
You can make it moving.
It's moving.
Okay. Yes, there is some compromise of the lumen distal to the stent. I think it is an extension of the hematoma. I will not leave it at the distal index of the stent. This may beget stentus thrombosis. I will stent it. Here, I would like to hear the opinion of Dr. Zahran, Dr. Karim, and Dr. Haitham as well.
Thank you, Ahmed, and thank you, Dr. Karim. I think we should think about the etiology of this dissection. Is it spontaneous or due to wire manipulation? I think here we can't ignore that the etiology of this long dissection may be this wire, repeated wire manipulation. So I believe in the presence of this large dissection, and the etiology here might be it's not a spontaneous coronary dissection, it's rather than an iatrogenic. So I think of stenting this large dissection is the appropriate decision, maybe the appropriate decision.
Okay.
Thank you, Dr. Karim. I think also about stenting this propagating hematoma, but I will suggest first to improvise or to use a cutting balloon if it's available, or to improvise a mechanism to do some sort of cutting of this intima first to relieve the hematoma before stenting it. Otherwise, I think stenting this segment with this hematoma can propagate the hematoma further distally. What do you think, Dr. Karim? I suggest adding a step to relieve this hematoma first, then stent this segment. If we do have the luxury of a cutting balloon or passing another wire and compressing this wire with a conventional balloon, try to make a crack inside the intima to relieve the hematoma.
Yes, Dr. Haitham, actually after we did work in this case almost about 3.5 to 4 hours struggling to have this STEMI 3 flow. So
again, the role of intravascular, the IVAC.
Yes, Dr. Karim.
I am hearing you, Dr. Ahmed. Further.
So my decision was to leave it and don't complicate, because stenting can propagate the hematoma more distally and occlude the vessel. Already now I have a TEMI 3 flow, and septals are filling. So this is most probably we are stenting in the true lumen. We are not stenting in the subintima. And the distal, if we go and rush after this hematoma, we can expand it more distally and cause apical infarction. So I prefer to go out with this STEMI 3 flow and non-significant obstruction of this hematoma, intramural hematoma. The use of cutting balloon was a valid option, but actually its role is not that clear Actually, I don't believe that much in this step, although it is written in the literature. But I'm personally, I don't believe in using cutting balloon to decompress the false lumen. It may expand it rather than occluding it. Once you crack it and you have a false lumen, how do you know that the hematoma comes from the subintima and empties in the true lumen and not the reverse? The flow goes from the true lumen and fills the subintima and expand the hematoma more and cause more distal obstruction. It's no one can guarantee that.
Of course, Ahmed, no one can guarantee that. It's written in the literature, and we've seen a couple of cases managed by cutting balloon, and the rationale here that we will stent this segment, so we will seal this crack, and we will prevent it to expand. It's just a vent rather than having a metal compressing a hematoma that will sure expand distally where the resistance is minimal. I think it's wise to leave it if we do not have a cutting balloon, or we do not intend to cut or release the hematoma first before compressing it with a stent. So I think it's wise to leave it if we do not plan to decompress it first.
Yes, thank you, Dr. Haytham. I really put the slide as you said, but I'm telling my personal belief. I don't believe in using it. It's my personal belief. But I would use it in proximal lesions if I need to decompress a hematoma in a proximal vessel. Also, cabbage was a valid option to send this patient if we couldn't succeed to open that LAD. And thank you.
Very nice cases, Ahmed, actually, with a very excellent discussion. And as always, Professor Karim Saeed highlighted the most important debatable points regarding the decision making. We have gone through a very long time showing those two cases. So I will pass the mic quickly now to my dear friend, Dr. Karim Mahmoud. Karim will show an interesting clinical case also involving a very big discussion, and Professor Karim Saeed will also give us the valuable points to learn and how to decide regarding this case. So please go on, Karim, and thank you so much.
So, hello, my dear friends. This is the third case for today, or the fourth case for today. This is a 64-year-old lady. She is not known to have a diabetes mellitus or hypertension, and this was her first presentation with typical angina of a 5-hour duration. On admission to a non-primary BCI hospital, her blood pressure was 100 over 60 millimeter mercury, and heart rate was 130 beat per minute regular. So and this was her ECG on presentation. As we can appreciate, there is a ST segment elevation in the precordial lead involving V1 up to V6, with T-wave inversion in the V2 up to V6. As well as we have a sinus tachycardia. The heart rate is approaching 120 beat per minute. So at this non-primary BCI hospital, thrombolytic therapy was given in the form of streptokinase. So after fibrinolysis, her blood pressure was 80/50, and her heart rate was 100 beats per minute. And as we can appreciate, there is a persistent ST segment elevation on her ECG. So they started at this hospital noradrenaline, as they consider it to have a cardiogenic shock, and referred to our facility with primary PCI service. On presentation, her blood pressure was 100/60. On the vasopressor, her heart rate was 130 beats per minute, and it was regular. Interestingly, she had an ejection systolic murmur over the left parasternal area, grade 3/6. When we inserted a central line for her, her CVB was 1 centimeter water. So we started a fluid resuscitation at the CCU. And this was her ECG on presentation, again with a sinus tachycardia with ST segment elevation, as you can appreciate. So we opted to do an echocardiography for this patient to exclude mechanical complication, as she had a ECG of anterior ST segment elevation myocardial infarction, and she developed a cardiogenic shock. So before sending her to the cath lab, we did an echocardiography, and you can appreciate this is the result of the bedside echocardiography. Here, if you can see, there is the heart rate is beating fast with some sort of anterior motion of this mitral valve toward the interventricular septum, and there is actually the basal segment looks contracting well, and we can appreciate here in this color flow that we have a turbulence across the LVOT in this view. This is the apical four-chamber view. Again, we can appreciate the motion of the anterior mitral leaflet toward the anterior septum, and we can appreciate there is actually akinesis of the apex and all apical adjoining septum. As you can here, you can see that the hypokinesis extending into the middle segment of the septum and the lateral wall. And here you can show the turbulence here again across the LVOT. And when we put a continuous wave Doppler on the LVOT, you can appreciate the presence of a significant gradient across the LVOT. So let's think about the diagnosis, and I want to hear from Dr. Karim and Dr. Zahra.
Okay, thank you, Mahmoud. Karim. I made the connection for some time, and I enjoyed this case while you are presenting the ECG that showed an anterior MI. So can I have?
She is a 64-year-old female with no risk factor, and she presented with typical anginal pain of a 5-hour duration to a non-primary PCI facility with the ECG you have seen in the first slides.
Okay. Can I have a look to the ECG again?
Sure.
So we have V1. Where is V1?
Here is a V1 with ST
V1 elevation from V1 to V6. Yes. So it is an extensive anterior.
Yes.
So this is atypical for anterior STEMI. What is not consistent is the presence of a cardiogenic shock with the low CVB and the echo. And the echo is showing obstruction at the level of the outflow tract with a good gradient. and distal regional motion assynergy. This situation can explain the cardiogenic shock with the empty ventricle, and this picture can be seen in patients with regular anterior apical infarction with compensatory hyperkinesia of the basal segment, creating this obstruction, especially with an empty ventricle. Also, it can be seen in patients with Takotsubo cardiomyopathy with distal ballooning and apical and basal hyperkinesia. So I can go for both possibilities. The action will be one to give a fluid to make this ventricle full, and so this obstruction disappear and the hypotension disappear as well, and to catch the patient immediately.
So this is a very good advice. What about giving a vasopressor to this patient this time? She was referred with a norepinephrine. Is this was beneficial or hazardous?
No, this may accentuate the outflow tract obstruction, and this may be a cause for the cardiogenic shock. The good management is fluid, especially the ventricle is not bad and the CVB is low. It was one, I think. So giving cautious fluid till having a full ventricle, and some patients with good hemodynamics may got benefit from beta blocker if there is no shock. So I will not go for vasopressor.
Exactly. And we did a fluid resuscitation for these patients. After this echocardiographic study, we went to the cath lab. Of course, we want to exclude the presence of occlusive coronary artery disease, as there is a different management for the two situations Dr. Karim has mentioned. So this is left coronary angiography. We see the left main, the LED, and the rapid appearance of the dye from the coronary may be due to the elevated left ventricular end diastolic pressure. As you can appreciate here, the LED showed no occlusive thrombus in this view, and actually also in this view there is no occlusive thrombi, and the right coronary artery was normal. And we document also the presence of the left ventricular outflow tract obstruction by doing a pullback from the left ventricle to the aorta that showed the presence of actual significant gradient across the LVOT. So after this angio, Dr. Karim, what do you think? It can be a thrombus that dissolved and give this picture, or is it Takotsubo cardiomyopathy?
The issue now, Karim, that we have this gradient that didn't improve with giving fluid. The patient was not empty at that time.
Actually, to be mentioned, we did this coronary angiography while we giving the patient the fluid. So she wasn't fully resuscitated with IV fluid, and the CVB is still somewhat low during this procedure.
So I will wait in the cath lab, giving fluid and monitoring the hemodynamic, maybe inserting a case in the left ventricle to monitor the left ventricle end diastolic pressure in order not to have a pulmonary edema with the fluid, to get rid of this gradient. And if this gradient disappeared, still, if it is even Takotsubo, I will go for intravascular imaging, maybe a disrupted plaque. And now it is recommended to do some form of intravascular imaging, even if you are suspecting Takotsubo. So I will give fluid and wait till getting rid of this gradient.
So giving fluid is a very good advice, and we continue really fluid, but we moved the patient from the cath lab, and the fluid resuscitation was done, and we will show the result of echocardiography after the fluid resuscitation later on this presentation. However, if we look to her laboratory, we can appreciate the presence of elevated cardiac enzyme, but the cardiac troponin, there was a modest elevation in the cardiac troponin, not consistent with an ECG of extensive anterior ST segment elevation myocardial infarction. We thought about the diagnosis of myocardial infarction with non-occlusive coronary artery disease based on the presence of a criteria of myocardial infarction with no significant coronary stenosis and in the presence of the acute left ventricular wall motion abnormalities. And if I believe my dear colleagues has explained the differential diagnosis of the MINUCA, it might be a myocarditis, a coronary artery spasm, or a myocardial disease such as Takotsubo or pulmonary embolism or oxygen supply demand mismatch. Actually, we thought about Takotsubo cardiomyopathy. If we look to the Mayo Clinic criteria for diagnosis of Takotsubo cardiomyopathy, it involved transient regional wall motion abnormality of the left ventricular mid segment with or without apical involvement. So most of cases of Takotsubo showed an apical involvement. However, some cases can occur without apical involvement, such as a reversed Takotsubo cardiomyopathy. The regional motion abnormality usually extend beyond the single epicardial vascular distribution. And the stressful trigger is often, but not always present in this type of cases. The absence of obstructive coronary artery disease or angiographic evidence of acute plaque rupture is another clue. And the presence of new ECG changes with a modest elevation of the cardiac troponin. In this case, we have that. Absence of myocarditis or pheochromocytoma. The myocarditis is a diagnosis of cardiac MRI, so we should do a cardiac MRI for this case. If we look to the European Society of Cardiology position statement, they also mentioned most of the criteria that have described by the Mayo Clinic, such as transient wall motion, the presence of the extent of the regional wall motion abnormality, the absence of the atherosclerotic coronary artery disease, new ECG changes, the modest elevation in the cardiac troponin, and they added two criteria, which is the elevated BNP and the recovery of systolic function on the cardiac imaging at follow-up after 3 to 6 months. And Takotsubo cardiomyopathy mostly occur in postmenopausal women. Chest pain is the predominant symptoms, mostly involve the LV apex, but can occur to mid-ventricular wall or other LV wall, and the compensatory hyperkinesis, as in this case of the basal LV segments, can cause an acute left ventricular outflow tract obstruction. This is a demonstration from Fronwald of the Takotsubo on the cardiac MRI. There will be a normal epicardial coronary artery with apical ballooning, as you can appreciate on the figure B. So, as Dr. Karim mentioned, we still in doubt, is it a Takotsubo cardiomyopathy or not? So, cardiac MRI was done to this patient at a later stage, let's say about 2 weeks after the presentation, and they showed no evidence of myocarditis. There was a complete recovery of the left ventricle with a normal left ventricular function. And this is her ECG. The ECG showed this deep symmetrical T-wave inversion in the precordial lead. And I think there is a very important criterion of the stress-induced cardiomyopathy, which is there is some prolongation in the QT interval, and we should be careful about this QT prolongation to not prescribe a QT prolonging drugs such as amacriles. And this is the echo after resuscitation. Here on the left side, this is the echo with the fluid resuscitation and the beta blocker. Here you can appreciate the absence of SAM in comparison with the echo on the image on the left side. No more turbulence of the color across the LVOT. Sorry, this is a hazy image, but the ejection fraction here was 72% by M mode. Here in the apical 4 chamber, there is a restoration of the normal contraction of the apical segment. And the LVOT obstruction was relieved, as we mentioned, with the fluid resuscitation and the beta blocker. Here you can appreciate this is the continuous wave Doppler at the index study, and this is after the fluid resuscitation and slowing the heart rate. So this patient was discharged later on ramipril 5 milligram, on bisoprolol 5 milligram, and she was doing fine. And this was a summary of this patient. She is a postmenopausal woman presented with what looks like a Takotsubo cardiomyopathy and left ventricular outflow tract obstruction. Her CMR at the later stage showed absence of myocarditis, so and return of the ejection fraction into a normal contractility, and this complete recovery occurred after a few weeks. So thank you so much, and I'd like to hear your valuable comments.
Thank you, Dr. Karim, for the good case. Actually, I was thinking that it could be an anterior MI that was spontaneously recanalized, and then that was a dynamic LVOT obstruction as a complication of the basal segment hyperkinesia as a compensatory to the apical stunning that caused by the MI. So it could be like an ST elevation, because here the ST elevation, it looks much more clear, and also the CMR that excluded any stress cardiomyopathy. I think it could be that dynamic LVOT obstruction as a complication of the anterior wall ST elevation MI because of compensatory hyperkinesis of the basal septum. What do you think?
Thank you, Ahmed, for your comment. First, I think the cardiac MRI can differentiate well between myocardial ischemia and the presence of myocarditis and the absence of myocardial edema. So what we mean, if this etiology was a myocardial infarction and resolved thrombus, we will have an evidence of subendocardial ischemia or some late gadolinium enhancement, maybe by the cardiac MRI. However, the absence of change with cardiac MRI, I think this is in the favor of the Takotsubo cardiomyopathy that is common to have complete recovery of the left ventricle after the few weeks. And if we look to the European position statement, there will be a complete recovery after a 3 to 6 week of the index condition. So,
okay.
Dr. Ahmed, Dr. Karim, please question.
Okay, I have a comment. Diagnosis of Takotsubo is done in retrospect. In this case, we are confronted with a patient with anterior STEMI. So we will manage it with primary PCI. There is no role for speculating this is a Takotsubo. In retrospect, after the complete recovery of the left ventricular function, now we will have satisfied the definition of transient hypo or dyskinesia with the presence of patent coronaries, and sometimes it will not be patent due to atherosclerosis in a patient 60 plus. So the presence of a patent coronary artery is not essential. However, the presence of the absence of a lesion that can explain this dyskinesia or ballooning is mandatory. So we have lesions that cannot explain the regional motion abnormalities. The second point is the role of CMR. This is very important to do MRI for all patients with myopia without obvious cause. And as Karim said, the normal MRI, despite being done very late, 2 weeks is a very late. CMR should be done very early. If it is a myocarditis, I should diagnose it very early, within the first few days, to manage it properly and to predict the prognosis. However, doing this very late is not advisable.
Yes.
So the possibility of STEMI with basal hyperkinesia or Takotsubo are two working diagnoses, and we will do the angio, and we will follow the echo, and we'll give the whole anti-ischemic medications. And after recovery of the left ventricle, and after ruling out of ischemia and damage by late gadolinium enhancement by CMR, now we are having a Takotsubo patients, which is very common in a post-menopausal females. I had a question for the symmetrical T-wave inversion after the event. This is described, and it is related to stunning of the channels. We have stunning of the myocardium causing this ballooning, and also we have stunning of the electrical channels responsible for the ST and T-wave changes, and it will manifest as some form of T-wave inversion for some period of time. Another comment in this case is a discrepancy between the troponin elevation and the ST segment elevation, which is not common. And also the magnitude of ST segment elevation is not common in such patients. Takotsubo myopathy patients tend to have 2 millimeter or around this figure ST segment elevation, not this high amplitude ST segment elevation. Thank you, Karim, for this very interesting case.
And thank you for your comments, Dr. Karim. Actually, to be mentioned, your comment is true regarding considering this patient Takotsubo. The medication I mentioned is a discharge medication, but actually during the hospital stay, she was on full anti-ischemic treatment till reaching or confirming the diagnosis of Takotsubo cardiomyopathy. So this is a very, very important point that we should deal with this case as an acute coronary syndrome and atherosclerotic coronary artery disease until proved otherwise by the cardiac magnetic resonance.
Yes.
I think we have a question from Dr. Hatem.
Yes, sir. Dr. Karim answered my question about T-wave inversion, but I'm asking about how long the patient will take medications. Is it lifelong or for 6 months or what? What's your opinion?
I don't have an answer for this question. What do you think, Dr. Karim?
There is no definitive treatment for Takotsubo. If you have left ventricular dysfunction, you will give ACI till the ventricle is good. Some patients tend to have some thrombotic lesions described, so we'll give aspirin. A beta blocker is a mainstay treatment in those patients because of the hypersympathetic status. However, the important thing to know is that those patients are more liable for recurrent Takotsubo,
Yes.
and the mortality rate in these patients is not low.
Yes.
And sometimes they manifest with cardiogenic shock, not related to this obstruction, due to the poor ventricle. So they may need mechanical support. So it is not this benign condition, and it is important to prevent its recurrence. So in my opinion, I'm not sure this is supported by expert opinion, is to keep these patients on beta blockers. And if the ventricle is impaired, ACI. Aspirin, no, I will not give her aspirin because we don't have evidence for atherosclerosis. Unless we have some evidence of thrombi in the coronaries. which is not the case.
Okay, sir. Thank you.
To be mentioned, Dr. Karim, I think there was a study that published in the New England Journal of Medicine comparing the patient of Takotsubo with myocardial infarction during the index hospitalization, and there was no significant difference regarding the mortality and the complication during the first hospitalization. So despite the complete recovery of these patients and the proposed favorable prognosis during the index hospitalization, the course might not be so benign as you have mentioned.
Yes, and the long term as well. They have a mortality rate, maybe something less than 5%, 2 or 3% like this in the first year. So it is not a benign disease.
Yes. So if we don't have any more questions, I'll pass the mic to Dr. Muhammad Zahran to continue the stream of this nice webinar.
So thank you so much for your valuable case presentation, Karim, and thanks again, Professor Karim Saeed, for this wonderful moderation and discussion. We learned a lot. I will pass the mic quickly to my dear friend, Dr. Abdurrahman Gamal, to finalize the session, and we will meet you next week, inshallah. So please go on, Abdurrahman.
Thank you, Muhammad Zahran. I would like to thank our elegant speakers today, Dr. Haitham Sulaiman, Dr. Ahmed Saeed, and Dr. Karim Mahmoud. And I would like to thank Professor Dr. Karim Saeed and Professor Muhammad Zahran for the elegant moderation of the day. Actually, Dr. Karim Saeed, as usual, took us to a very high scientific levels of discussions, comments, and questions and answers. To wrap up rapidly the three presentations, Dr. Haitham Sulaiman began with a presentation of a case of myocardial bridge in the situation of acute coronary syndrome, which he can elegantly can deal with the case. Followed by Dr. Ahmed Saeed, who gave us two case scenarios of SCAD. The first one was a female, which was common, but the uncommon was the right coronary and the PCI, which was justified scientifically and by each step. The last one presented by Dr. Karim Mahmoud actually he gave us a great case scenario of Takotsubo with precise literature and step by step how he can approach the case. Thank you all. And we will meet you, inshallah, at Saturday, continuing the congenital heart disease course, and the next Tuesday, the bifurcation campus through the Tuesday intervention nights, and the next Thursday, we will continue the clinical cardiology webinars, and we will begin, inshallah, in valvular webinars the next Thursday. Thank you all, and see you next week, inshallah.